Hello everyone, my name is Larry Williams and I'm the director of the Malone Community Center, and I want to welcome you to our center and also to this conversation series with Dr. Bridget Goosby. This is a very unique partnership with the University of Nebraska-Lincoln. Working with the Minority Health Disparities Initiative, we've formed a collaborative partnership with that organization or that group, and we are going to be bringing to you conversation series dealing with health disparities and inequities in our community and throughout the country. And Dr. Goosby is doing some very exciting and interesting work, and we're very, very happy to have her here. And with that, I think a round of applause would be quite great. Again, the Minority Health Disparities Initiative is something that the university has been doing, and I'm sure Dr. Goosby might talk a little bit about that, but the Malone Center is very, very happy to be part of this initiative and to be one of the partners in looking at health disparities and inequities in the people of color community. Dr. Goosby is quite qualified to speak on this today. She is the professor of sociology at the University of Nebraska. She has been a visiting scholar at the University of Texas. She's also been a visiting scholar at the Institute for Poverty Research at the University of Wisconsin in Madison, and also at Northwestern University. She's also written many, many papers dealing with health inequities and also people of color concerns and issues. So again, we're very, very happy for her to be with us today. This is the format that we're going to use. Dr. Goosby is going to talk briefly about some of her work, some of her research, probably for 15 minutes maximum, and then we're going to open it up for questions and answers, okay? This is being recorded, so we ask that you speak loudly. And again, we're very happy that you're here. I think I counted close to 40 people that are here today. It shows an interest in the subject and also a commitment to making things better within our community and throughout the country when it comes to inequities in our health care. So with that said, it's my honor and my privilege to introduce Dr. Bridget Goosby. Thank you.
So I really appreciate the opportunity. I thank Larry and the Malone Center, as well as the Minority Health Disparities Initiative, Kirk Dombrowski, who's the director of that in the University of Nebraska-Lincoln. The important thing to note here is that the Minority Health Disparities Initiative is actually a relatively new initiative in its current form. It's really exciting the way that they're reaching out and connecting to the community in ways that are unique and exciting. And so I'm thrilled to be a part of this process and this opportunity, and feel free to ask questions. I really do see this as a conversation, but I do want to start by noting a little bit about the work that I do, my research background, and also I would be remiss if I did not talk about the fact that my work that I'm doing and that I'll be talking about today has been funded by the National Institute of Health, the National Institute of Child Health and Human Development, NICHD, also the University of Nebraska Office of Research and Development, and the Social and Behavioral Consortium also at the University of Nebraska. So I've got a tremendous amount of support, institutional support for the kind of work that I'm interested in doing, and I'm going to be talking to you a bit about today. And so one of the things that you saw on the flyer is that discrimination is clearly a key and important factor that contributes to health disparities. And I assume that a lot of you are here because you feel that this is a really important topic of discussion and one that is part of the Nebraska community as well as the Lincoln community. And so one of the things I'd like from you all is if you could all give me some feedback about what are the types of things, is this something that, am I right in that this is a really important topic of discussion, and what are some of the ways that we can get more people in the community involved and engaged in the kind of research that we'd be interested in doing in the community. So discrimination is something that I came to and to understand through my own deeply personal experiences. But one of the things that is really has come to note in the past, I'd say in the past 15 years, and there's a growing literature, is around the consequences of racism and discrimination specifically for minority health, but also more generally social exclusion for health. And so one of the things to talk about globally is the fact that social exclusion, people feeling left out or people being marginalized, whether that be because they're low income, whether that be because of their background, their sexual orientation, their racial attribution, all of these sorts of things can be harmful and painful for people's health. It can get under their skin and make them sick. Why I'm interested primarily in African American communities and communities of color is that communities of color, and in particular African Americans, they experience the social exclusion, discrimination, and marginalization more often with greater severity, thus really shaping their health outcomes in terms of these stress-related conditions. And so I was looking through some of the statistics for Nebraska specifically. So Nebraska is on average generally a more healthy state than other states. However, when you break down by race, you start to see some real differences. And so I'm not going to give you explicit numbers because you can actually get them there's an African American socioeconomic profile for Nebraska that was printed. I think this was Nebraska Department of Health and Human Services did one. There are some Place Matters here in the Community Health Endowment has a really interesting report on place here in Lincoln. But one of the things that the health conditions of note, particularly for the African American community, are that African Americans have the highest blood pressure rates and hypertension rates in Nebraska. They also have some of the highest cardiovascular disease prevalence in Nebraska. Diabetes, they're second highest in Nebraska. They are, American Indians are the first. And also following American Indians, they have the highest rates of obesity in Nebraska. And so here's what's important to note about this when we talk about this in the context of the stress of discrimination. So discrimination is something that can happen at a structural level, right? So we can see discrimination happening where people are not given equal access to resources. So not having access to resources, not having access to high quality schools, access to getting into universities, high quality jobs. These are things that have a snowball effect structurally that can impact African American health and the health of people of people of color. Now, what's also important, and is increasingly in psychology more so, is this understanding that microaggressions, or the experiences on a day-to-day basis of feeling treated unfairly, having people not treat you like you're human or being dehumanized, these are the sorts of things that, if they happen on a regular basis, can literally alter your biology. And so in the sense that, and I've got some papers that I've done on this process where talking about how when you experience some sort of stressor, your blood pressure increases, your blood sugar circulating in your body will increase. These are things that are adjustment to initial immediate stress responses that can be healthy. But if they happen chronically, if you chronically experience some sort of stressor, this can lead to things like elevated chronic high blood pressure or hypertension, risk for cardiovascular disease. Diabetes is one that can be exacerbated by stress. It can also shift your behaviors. It means that when you're under a lot of stress, you're more likely to eat unhealthy, thus increasing this risk, right? So you have these kinds of things that, and then you, on top of that, have, if you are in a group that structurally doesn't have access to the resources to get the health care that you need, eat the healthy foods that you need, be in the kinds of schools that are safe for your children, all of these things can compound to impact health, right? And so these are the things that are very, very important to me, and in the work that I've done, we're actually understanding the biology of stress is something that I came to very late in my life, 5 years ago, and I got funding from the NIH to actually learn about this process because I think that it's important when we try to understand what goes on with these health processes within minority communities. And so understanding what goes on under the skin to actually shape these population level health outcomes becomes extremely important. But even more important is what happens in our local communities. So I talk about this from a population researcher perspective. So I have a lot of papers that look at national data where we look at how these things like discrimination, going to predominantly white schools and things like that are related to health outcomes for minorities. But what I'm also interested in is in what happens here in Lincoln, because Lincoln is actually an interesting place, and a unique place in that we have a very small African American population, but a surprisingly high biracial population of kids of African descent, and we have a lot of integration, right? So whereas a place like Omaha has a lot of spatial segregation of minorities, Lincoln is a very integrated place. And so what's interesting is that not only is the socioeconomic integration there, so that low-income people live in proximity, it's kind of not as much as we would think with this Place Matters report, but there is some proximity between low income and high income, but also that African Americans and people of color have regular interactions with the predominant group. That it would be it's interesting to understand how health is shaped among these different groups. And so again, I should note that the work that I'm doing here is really about social exclusion and how it impacts a variety of different groups. So I want to understand how being low income might shape people's stress. So being marginalized because you're low income, or being marginalized because you're a minority, how this might shape stress. But I also want to understand in the African American community, how can we begin to start understanding what goes on in their health processes when they have experiences here that are related to race-related discrimination? So I have a team of researchers. We have actually done, and some of you in this room, if you have a child between the ages of 11 and 15, may have gotten a survey from us. We mailed out surveys to ask questions about experiences of exclusion, but also about people's health and well-being. Surveys were sent back, and from the surveys that we got back, we asked a subsample of people to come into the lab where we collected biological specimens, as well as to ask people questions about stress, about their health, about experiences of discrimination. So in terms of the biological markers that we collected, and I'm happy to talk more about this if people have questions about this part as well, is we collected hair for measuring stress markers. We collected blood pressure. We collected body mass. So we collected height, weight, waist circumference. We collected saliva, and from the saliva, we wanted to look at stress-related genes. We have a subsample right now that we're introducing, and we're asking to measure sleep. So we're going to be basically doing daily diaries with people who were part of the study, asking them questions about their daily experiences, whether they experienced something stressful over the course of the day, then measuring their sleep with these little actigraphs. So then we'd be able to collect over a 2-week period, are there stressful conditions that affect their health? This is important because sleep is so huge and it affects so many different health outcomes that this is another pathway when we talk about minority to health disparities. People of color, and particularly African Americans, get a lot less sleep and poorer quality sleep than other groups. And so we're really trying to look at an array of different health outcomes, blood spots, and from those we're collecting inflammation, immune function. So we have like a variety of things that we're interested in looking at. And so one of the challenges that we've had is people participating. And so we want to be able to, get a sense. Part of this is to kind of get a sense, like what kinds of things can we do differently as researchers to help get people more involved in these kinds of data collections, because these are the kinds of things that we can provide to policymakers, stakeholders. We want to be able to provide this information. We don't want to just publish in academic journals. We want this to actually get back to the communities so that we can begin to address these kinds of issues and do concrete kinds of interventions here. And so with that, that's just my introduction. And so do people just in terms of how we start this conversation, with the evidence growing that discrimination is a key factor for poor health, do people actually think that this is something that is contributing to poor health outcomes here in Lincoln?
Hi, I'm Paulette Jones. Okay. I know that it does disproportionately affect minority communities as far as healthcare and poverty, because oftentimes people of racial and ethnic minority populations, of ethnic and minority populations, don't have the access to care that's needed, because even in Lincoln, we have a clinic in the neighborhood that people say you're supposed to go to whether you have money or not, you have to pay $35. Okay, so that's 30 or 35, whether you have a job or any income coming in. And so, no, there are times there are people that really can't pay that. So, their health care suffers. And then the other thing is, oftentimes, they just go to the emergency room for, they wait until they have to go to the emergency room because they don't have health insurance and no way to pay to even go to the clinic here that's supposed to be serving the community who are less able to pay. So that's my comment.
Thank you, Paul.
I looked at the Community Health Endowment Annual Report, which was amazing. My question is, how much of the coalition is where you live versus race and things along that line? For example, here in Lincoln, and we are getting better, and we're better than Omaha, for example, and other communities in terms of segregation. We still have some pockets of that. We're getting better. We got a long ways to go, though. But in Lincoln, for example, I think there's only 2 doctor's offices that are north of O Street. Very few. All the hospitals in Lincoln are on the south side of town. The urgent cares are on the north side of town. We talk about food deserts and things about that. Even one of the things in there were physical fitness facilities, for example, are just primarily not on the north side of town. So access to these types of things. What is similar people who are not a minority but live in that area, are they seeing the same type of thing, or what's the connection there?
So this is an interesting question, and I think that one of the things that is very clear from the Community Health Endowment study is that we have a pretty significant low-income population, and they're predominantly Caucasian low-income population with lack of access to resources. So that's certainly, that particular population is one that is in dire need of help, and they are also a group that is socially marginalized and in some ways very invisible. So we don't have the access to care for that population is one that is a key factor that needs to be addressed and a public health issue here in Lincoln. What the distinction here, so race matters, and the way it matters, however, is the fact that African Americans tend to be disproportionately represented in poverty. So whereas they aren't numerically higher, right? So more whites are poor, African Americans are disproportionately, for the proportion that's here, more likely to be in poverty and more likely to be deprived of care and more likely to live in these places where they do not have the same access to resources. So I think that, so these two populations indeed are extremely important in terms of the marginalization that they experience and the access that they need and attention that they need, but there are circumstances around it that are different, that are because of the kind of historical legacy of inequality that Blacks have faced here and nationally. So yeah, but that's a fantastic point.
I'm curious if you could talk about, when you use the word health, are you talking primarily about physical health? You're not including mental health, or is that a part of your, I mean, I think it's a hard part, but is it a part of your research?
Yes, I love this question. I'm very excited. Okay, so, because I actually started as a mental health researcher. I was interested in the role of poverty in general for the health, mental health of families. So, well, regardless of race, I wanted to understand how poverty was affecting, you know, the psychological health and well-being of families. What increasingly I became interested in was understanding the link between mental and physical health, because these things are really hard to unravel. But what's interesting about the African American population is there is a tendency when we measure mental health in African Americans that they are less likely to be measured experiencing things like depression or anxiety. And so the question was, well, are African Americans physically they have worse health, but mentally they may be doing psychologically better. And so increasingly I became interested in understanding how these things are linked together and did some work on depression and pain and how those things are linked. But I think the work, so my earlier work really looks at mental health. My later work starts to look at stress and physical health, but stress is one of these things that's both psychological and physiological, right? So we perceive things as stressful consciously, but we can also subconsciously, our brain is always responding in ways that, there's a professor at the University of Michigan, Dr. James Jackson, who is like the trailblazer in minority health disparities among African Americans, who argues that African Americans, while they experience tremendous amounts of stress, the thing that offsets their psychological well-being is the fact that their diets are different, right? So eating things that will cause dopamine drops, right? So just eating like lots of unhealthy foods, these things is part of particularly around the South, right? Eating fried foods and high-fat foods. These are things that make us feel amazing at the time that we're doing it, but then have all of these kind of downstream consequences physiologically. And so this is one of these processes through which African Americans have been able to cope, and the poor do it as well, and part of that is access. I mean, you end up ultimately eating the things you have access to and preparing the things that you have access to, but these things can have, immediate kinds of offsetting of mental health responses, but can then cause all of these kind of downstream physiological problems. And so the work that I do is very much, I'm always asking mental health questions. I'm always asking physical health questions. The biological markers that I'm measuring, I've got a colleague who's doing neuroscience, so we're looking at how responses to discrimination affects the brain and the downstream stress effects. So yeah, that's really, the work that I do is definitely not independent of mental health. It kind of is the whole overarching stress-related health condition. So I have a question for you all to kind of give me feedback on. Do you think that the experience of discrimination can have impacts across generations? So one of the things we're interested in is understanding how the experience of discrimination works in minority kids' lives as well as the lives of their families. And so are there ways that you guys think that these experiences, are they happening in the schools? Like, are kids of color experiencing, race-related stressors, even, so I'd also like to know, are low-income kids experiencing, class-related stressors, right? So these are things that are interesting to me as well.
Yes, they are.
And
It's very evident that some kids coming to school, I started out at Lincoln High, ended up working in the elementary schools. Some kids come to school prepared to come to school. They have new clothes on the first day, they've got books, they've got notebooks, pens, pencils. Some kids come to school without having their hair combed. And I really believe that those first couple days of school makes a huge difference in how kids are treated and how they in turn treat other kids. Your school social workers have tremendous job to do, not enough resources, too many schools. They're moving so fast, they really don't have time to solve a lot of individual problems. So that's one resource that I think could be made better use of.
Maybe one of the other things we could talk about too are about kids of color going to predominantly white institutions. I can speak specifically, I went to the University of Wisconsin for 4 years, and although Madison, Wisconsin and Milwaukee are communities that have larger people of color communities, it was not a very large black student population, and I know that could be something that we could talk about. And I don't know if it manifested itself into any physical, but it was stressful at times to be in a predominantly institution. And I could say the same thing when I came to the University of Nebraska. Again, being a person of color, and again in a predominantly white institution, trying to achieve higher education.
So kind of similar to what Larry, is that correct? Larry was saying, I work in the high schools and see, of course, white teachers in nearly every classroom, white administrators in every building, and the way that language is policed, the way that dress is policed, those are ways that racism is experienced in schools by young people. That doesn't get named racism, except by the students oftentimes, and then they get put in ISS, so there's no real conversation about was that a racist interaction. And man, so I'm sure, I would guess that that has an impact on their bodies, causes more stress. Going to school is not a place that they want to be or feel welcome or are treated as an equal part of the community. But then also, if you look at the correlations between education levels and then income levels, and then the correlation between those things and health outcomes, it's compounding in many ways in the school systems, I think play a huge, huge role.
That's a fantastic point. And so to piggyback off of that, yeah, there's been a lot of research looking particularly, well, increasingly African-American girls are experiencing this, but Black boys generally tend to be suspended from school. They're more likely to be expelled from school for engaging in behaviors that would be considered creative for white children, but for African-American children, it's considered disruptive or problematic. I just actually saw a report on some little boy who was suspended from school for staring at a young white girl in the classroom, which kind of reminded me, smacked of kind of Jim Crow South to me, that these are the kinds of responses to Black children in the classroom. And so it can start very, very early. There's been psychological research done on dehumanization of Black children, and that Black boys tend to be thought of as older and more mature, but at the same time considered so that they should be held to a higher standard of behavior and punished more severely for their behavior than comparable white children, but at the same time are considered less than human at the same time. So they're in this catch-22 that at some point they stop, and I've had this conversation with African-American mothers who say, I have a young boy who's cute right now, but at some point he's going to stop being cute and start being dangerous, and this really terrifies me about being a mother raising a Black son. And so this is like a very real stressor. When I talk about stress, the stress is not just happening to that person, but it's happening to the family who's having to navigate and manage the safety of their kid. And when you have parents who have to deal with their children being suspended from school for something that may not necessarily have been it might have been innocent, but because of this implicit bias that may not even be conscious by the teachers in the school, they've decided that this child is a problem and it has a lot to do with their racial or ethnic background. This has a cascade effect, right? So this young woman was saying how this can affect the child's motivation. Motivation is, I just read a study that shows that motivation is actually a huge predictor of IQ. So IQ is not something inherent. It is not something you're born with. It's something that's affected by the social processes that you experience, and that motivation is a key contributor to people's IQ. So this argument that African Americans have a lower IQ is tied up in a lot of different inequalities and processes that minorities experience over the course of their lives. And so this is one of the reasons why, in terms of understanding the life course and how health and any racial inequality can affect health, this can start early. It can start as early as the womb. African Americans have higher infant mortality rates. They have higher premature low birth weight offspring. It's been linked to exposure to discrimination. And so this sets a cascade of health conditions for the child if they're born low birth weight or premature. So, you know, these are things that, you know, there are multiple stages of development where this can be an issue. But I think that to Larry's point about being in predominantly white environments, I've actually published some work on the experiences of kids in middle school and high school when they are African American kids in predominantly white environments have worse health outcomes later. And so the stress of being in an environment where you could be potentially microaggressed against on a regular basis because you're around kids who may not necessarily have ever interacted with a person of color. And so what they get, the information they get is, you know, from entertainment, from the news, right? And you can imagine what this does to people's perceptions of minorities, and when all the information you're getting is not from your interpersonal interactions, but from the media. And so this can have real impacts on people's feelings of being included. That can be really challenging going to school in elementary all the way up through secondary education and college.
So I'm thinking of what else is generational. handed down is I think marginalized people in general don't know how or don't have the experience of being consumers of healthcare.
Of what?
Of healthcare. And I think that can be pretty devastating and passed on and on. We're not taught how to be good consumers and what our responsibilities are as a consumer and what we should be expecting as a consumer. So can you talk about that?
Interesting. So there's a level of, so there's two sides to this, right? So on one side, yeah, so access to quality care is something for marginalized groups that they may not be accustomed to, right? So even when there's access to care, being treated poorly when you go in is going to dissuade you from going back. And so this is one of those things that, and it is not just among low income. I can tell you from experience, it is not just low income people who experience bad care when they walk into a doctor's office. But I think that this becomes important because the other side of that is being agents of our own health, right? And being willing to go into a doctor's office because it's more of a, sociologists have talked a lot about the culture of the middle class. And part of being the middle class, and I would say like middle class Caucasian Americans are socialized on average to have more agency when they go into these kinds of environments. So they're like, this is my health, this is my child's health, and you're gonna do whatever you need to do to make sure that my child is healthy or to make sure that I get the care that I need, right? Whereas low-income populations and traditionally marginalized populations may tend to be more deferential to people who have the experience and the degrees and say, well, this person knows what they're doing, so we're just gonna defer and say, okay, apparently this is how it's supposed to be, even if it's like the worst care, right? And so there's this combination of these things happening, and the challenge becomes, if you respond in a way to be an agent of your own care, do they see you as an aggressor in the doctor's office, right? Because then you have the whole issue of implicit bias when medical people come in and they see a person that doesn't look like them and have stereotypes about them. It becomes a challenge in terms of what kinds of treatment you're going to get, even if you try to decide to exercise your agency in that environment. I think one of the things that becomes really important about that, one is educating people in the community about making sure that they understand that they can be agents of their own care, right? But also, on the other side, for providers, having them do the training and understand that when they engage people from marginalized populations, that they may be coming in with a whole set of preconceived notions that may color the way they actually provide care for this population. And so I think that becomes really important on both sides to kind of understand how we can begin to engage in conversations and communication around our health in ways that we can improve that on both sides.
My name is Pastor Janet Goodman-Banks, and I'm the breast cancer outreach nurse here at the Malone Center, and I work closely with my boss, Larry Williams, and with Ms. Regina Sullivan, who's the health specialist. Just to piggyback off of what was said about the generational interpretations of healthcare, and you speaking on basically advocating for yourself. I know that in my family, the doctor was God. I mean, you had to wait and drive 2 hours just to get to one in the South, which I'm glad I was not raised down there. But even then, their quality of care was not the same as those of whites. I mean, we can look at the Tuskegee report, what happened there. They made a movie out of it, Miss Everett's boys. I look at it even now. I am a nurse, and we do deal with the African American populations, Regina and I, and the concerns that they have in not being treated like others. Money is also an issue, and sometimes we have to advocate for them, and we really don't mind doing it. I'm a breast cancer survivor, and breast cancer care is extremely high. Co-pays and medication and all that. Thank God for me, I have pretty much great doctors, but that's not always the case. Everybody don't feel the same way about you. Everybody does not want to invest their time, money, or energy into you. So, and I can say that educational-wise as well. I mean, there weren't a lot of African-American women going to school for nursing, and those of us that did, the first thing they said to me was, "Do you work in the kitchen?" And I'm like, "I'm a student," you know? So, and I remember my son, in the 8th grade, you had to test to see if, when you went to high school in your freshman year, if you would be eligible to take algebra or not. And you had to score an 80 or above to go on to algebra as a high schooler. Well, he scored 80, and the instructor called me at home and said, "But I'm going to place him in general math anyway." I said, "But he scored 80. She said, "I know, but that's usually what we do. We just place them all." I said, "What all? Who all?" So you place all the African-American kids in general math, and he scored 80, which was what was required. You had better place my son in algebra.
And so these are important, so thank you, Pastor Janet. This is really, these are the kinds of things when we talk about the processes and how many layers are involved in the trajectories that people end up on. There are all of these different paths that can happen over the course of your life where people can make a decision based on some kind of perception or stereotype that can literally, had you not advocated for your son, probably would have changed his whole academic trajectory, right? And so, but these kinds of things, and the fact that you were asked if you were in the kitchen, I mean, I've had situations where people were surprised that I'm a professor, and I still have those moments. And so I think that these are all kinds of the issues that, you know, persons of color just are perpetually, constantly having to navigate and manage.
I think what you had talked about a little bit ago seemed like cultural competency. That, like you said, or somebody said, Janet said, even if you do go to the doctor, sometimes you're not perceived well. I want to know, since you do studies in MHDI, that university's program, okay, you're getting research and you're doing studies. What, if anything, are you guys doing, or is anyone doing in the community to assist in giving or providing cultural competency trainings for medical providers? Because I've been in healthcare off and on for several years, and I know that as part of one of my positions I held in healthcare, I had to provide monthly cultural competency training for all the staff. It was a clinic, all the staff, as well as the medical providers. So who's addressing the inequities or whatever, the problems with cultural differences?
So I wish that our colleague Mindy Anderson might have known more about that than I do. I'm not actually qualified to answer that. I will say, to be clear, that from the university perspective, so the university, we're primarily doing research. And so the important part of the research is then making the leap from that research and the findings from that research to get to the appropriate community partners to structure interventions. And so I personally I'm a researcher primarily, and so my goal is to do work that ultimately can be funded by places like the National Institute of Health so that we can get that information. MHDI is instrumental in helping me to share that information with the local community, with the at the national level as well. And the hope is that we can find community partners that can help with the intervention component. And there are people at UNL, at other places, that they specialize in interventions specifically, but that's not something I specialize in, and so I don't actually know, I couldn't answer that question specifically. But I do know that there's a lot of research out there, I don't know if it's being done here at UNL, but there is a lot of research being done about kind of interactions in doctors' offices and access to care, and how the differences in care, the quality of care, based on interactions that people have and the race of the patients.
And that's one of the reasons we're having these type of conversations here, is to make sure that people understand some of the concerns and issues that have been uncovered in research regarding inequities in our healthcare system, not only just for people who are poor, but specifically people of color and African Americans. And that's one of the reasons we've partnered with the university, is to take what they are doing on the research side, bring it into our community, and then the community can use it, especially the Malone Center, and probably writing grants and seeking funding for programs that will address the inequities that are going on in our healthcare system. So yeah, that's one of the great things. I don't know if it happened because we joined the Big Ten or whatever, but that is one of the things that I'm very thankful for, and that is university is reaching out to the community to share with them research. So it's not like an annual report or a strategic plan, you're done with it and it sits up on the shelf and gathers dust and nobody looks at it. I'm very thankful that the university is doing that and bringing their research to us. Now we can take it and go forward. Any other questions? Dr. Goosby, can we talk a little bit about biracial kids?
Yes.
Yes. I have a biracial teammate, excuse me, Sister Regina. And it's a difficult thing. It's very difficult working with a biracial kid. There are so many stress factors going on that probably he doesn't want to share with me, but I sense it and I see it. And maybe you can talk about discrimination as a biracial kid and what happens and what does it do?
So what's really, and thank you so much for bringing this up, Larry, because one of the things that we found in our preliminary research out here in Lincoln was that biracial kids here, on average, have higher levels of kind of psychological distress and report kind of generally feelings, having, more depressive feelings and things like that. Now, one of the things that's important to note about this population is that we don't know a lot about this population. Biracial youth are one of the populations that are growing fastest in the United States, but they're a population that's still under the research radar. And part of it has to do with the census is just like, it's really complicated. We don't know what to do with all these different combinations, right? So we end up not knowing much about anything. So one of the things that we did was target biracial kids with one African American parent. The other parent could be, it didn't matter what race they were. But one of the things that we were interested in understanding and we want to know more about, and I think my colleague Jordan Salis in communication also does work on biracial youth, is understanding the process through which feeling marginalized affects their health. Because I think that for biracial kids, it's even more amplified for them in some ways than it is particularly for African American kids, because they're straddling two different identities and have the challenge of people on both sides of their identity potentially saying, you're not enough of this or you're not enough of this. And so I've had several, biracial youth say to me that, they get at about 14, people start asking, what are you? And so then the question becomes how they respond to that. But, African American kids say you're not black enough, and, white kids say you're certainly not white. And so then having to deal with who is your community? Who are the people that are inclusive for you? And a lot of biracial kids grow up in single parent families, and in Lincoln in particular, it tends to be Caucasian moms. With children with an African American father. And so the challenge then becomes how connected are they to the communities that can provide them with the support that they need. And so there's this challenge of racial socialization and what that means for them. But it also means that there's an added layer of stress for them that could be manifesting in ways that we don't actually understand because we don't have a lot of research on them. But I would hypothesize that for these kids, if they don't really grow up in an environment where they're feeling included, that this can be an added stressor that becomes really challenging for them, both behaviorally, psychologically, and can begin to manifest in physical health outcomes later on. But this is an important population, particularly here in Lincoln, that we just don't know anything about, and one of the populations that we're really trying to target with our research, because we want to know more about their experiences and understand how this is impacting their health.
How does that affect how you look biracially? I mean, in the sense of
Yeah.
biracial children can look very white, just as black women. The lighter you are, I think that has a lot to do with it.
Right,
the
right.
more, the better you're treated.
Right.
So I'm wondering how those factors, and then how do the kids identify with themselves? Do they view themselves as being black or having any black culture or anything like? So those are kinds of factors that have come down through history when you're looking at shades of colors of black people. So
that's a great point. And phenotypically, so we call that a person's external phenotype, right? So how a person looks, and there is research showing that the darker your skin, the more disadvantaged you are, the more poorly you're treated. Right? So, but what's interesting, and so that becomes a complicated issue for biracial children too, because phenotypically they vary across the spectrum. So, you know, they can go from having straight hair and blue eyes, and then it becomes a question of whether they identify. Because they don't necessarily, unless someone sees their parent, they don't necessarily have to identify that way. But then there is the whole aspect of a young woman basically said when asked, she was biracial, but phenotypically she was clearly of African descent. How do you identify? Identify as Polish. I was like, oh, okay, all right. So, you know, you have these different, kids are thinking about these things in very different ways and identifying in very different ways. And literally, so much of that depends on the households they come from, the networks they're in. There are like biracial networks now that are popping up everywhere, which is really exciting for biracial youth, because now they can start to feel like they've got communities, of people that are experiencing, that they can share their experiences with. But the phenotype, physical appearance is hugely important and can't be, downplayed by any stretch, because I think that physical characteristics have a lot to do with how people tend to be treated. And there's a lot of research demonstrating that physical characteristics, that more fair-skinned people do better economically, socially, and so that's one of these things that is hugely, hugely important.
And medically, for a long time, there was the one-drop rule.
Right, right.
Didn't matter how light you were or whatever. There was one drop of African-American blood, you were considered black. I mean, you weren't even asked, what race or, ethnicity you were. That medically, they placed it on your sheet automatically. Now I'm glad that this biracial community has a voice now with the different networking, that they can express themselves.
Yeah.
We're running out of time. We have about 5-7 more minutes. I see I have another question here.
I suspect I know the answer to this because you're the researcher. I get that, and I appreciate the information. But what can we do? And maybe you probably haven't done research yet on that aspect, but what best practices are out there? Is it a matter of education or empowerment, access, intervention? What can we do to make these, and the things that we can do? I can't get a hospital to move from the south side to the north side, but what can I do? What can we do to change these things that we see? And another side comment, we also at the Salvation Army do a lot of work with refugees of African descent, and we're seeing the same thing as well, even worse there because they're really caught between several cultures there. But anyway, what can we do to make a difference?
Well, that's a big question, and so that's why I'll never not have research, because we're still trying to figure it out. I think that part of what becomes important is all of us being advocates all of us being vocal, even if it's in just our interpersonal interactions with people, if we can be advocates for people who don't have a voice or who are marginalized, calling people on it when they're being a racist or classist or, these sorts of things. We can also hold our politicians' feet to the fire at the local level, at the state level. That's where a lot of these inequalities, that's where we as, just citizens can make more of a difference. There's only so much we can do at the national level, but at the local level, if we can begin to have these conversations and say, this is what the research is telling us, and just don't let up on these politicians in making sure that they understand how these processes are working in our schools, in our communities, in our hospitals. And so I think, as a concerned citizen, that's what I would say. As a researcher, we can always do more research, but there's a lot of research already out there demonstrating that there are these systematic inequalities. We've got the annual report from the Community Health Endowment. We've got the African American profile. We've got reports on the Native communities in Nebraska, right? We've got a lot of this information, and we're continuing to push that information, do that kind of work, but then we need to make that next step, and we need to call our, call our local leaders and say, well, what are we going to do about this? What are you going to do? How can we as a community come together? And so, I would just say that, more generally, I think that this is one of the things that we can all do, not just as somebody from the university.
I was just wondering if within the Black community, is there discrimination based on your skin color or tone?
There's been literature showing that yes, that does happen, that it's not as bad as it used to be, but it has been one of those things that has been an issue in terms of internalized racism. And so that's what we call it internalized racism kind of within the community. And a lot of the importance of how that happens is the internalization of what's considered beautiful, what's considered socially acceptable, and understanding that, our community for a long time and still has been perceived as darkness is less attractive. Period. And so that has internalized. And so in the Black community, there may be these implicit biases associated with darker skin tone being less attractive, or you're less intelligent if you're darker. Certainly in my family, I grew up in the South, my family, it was very dramatic when my grandmother married a dark-skinned man. And so it just became this whole issue. And so, these are the kinds of things that, sure, culturally over time, but these are things that have been part of our systematically racist structure that a group of marginalized people have internalized and has led to these kinds of divisions within the Black community. But, I don't know of any. More of the more recent research has been around skin tone and what that means for, and actually African American mental health. Darker skinned African Americans are more likely to experience depression and anxiety, worse health outcomes, things like that, which again is part of this whole process of how people are perceived and how they're treated. But still, light-skinned African Americans on average have worse health profiles than Caucasians do. So, there are these gradations in risk that are related to not only people's physical appearance, but then the structure in which they're in.
When I was thinking about this topic in this upcoming conversation, I kind of went back to my former life when I was at the Commission on Human Rights. And I was thinking about some of the women that I interviewed. Many of them were white women, and they had been sexually harassed in the workplace. And many of them had just been traumatized, and it was difficult for them to even talk about it, to even report about it, and then to even deal with it. Not only were there mental manifestations, but I believe there were also physical. I wasn't a doctor, but it was clear to me what had happened, and I guess I really didn't see the forest for the trees. Now, again, we're talking about African Americans, but I guess I bring this up to say that it affects people, period. And I know for a fact some of the women that I interviewed who had been horribly treated in the workplace, sexually harassed, were traumatized. Trauma, that's part of the deal, isn't it?
Absolutely, absolutely. It's a perpetual historical trauma, and we've heard this term used, researchers use this term when talking about the American indigenous population, that they experience historical trauma, and that this trauma is something that is passed down from generation to generation, the extreme loss that they've experienced and continue to experience in their communities. This is absolutely appropriate when we talk about African Americans as well. I think that when we talk about the historical legacy of slavery, we are still seeing it. We are seeing it in youth being killed, and people getting off when it happens, the stress, again, of what happens to children, black children in classrooms, what happens to black faculty when they're microaggressed against by their students. It happens, you know, whether you're middle income, whether you're wealthy, you can ask the president, right? Whether you're low income, these processes continue to go on, and they're unremitting, and this is one of the reasons why discrimination is so essentially important to understand, and how it affects people down to the biological molecular level, that having these sorts of processes go on over and over again from the time that you're, you know, literally being born, right, or in utero, your mother being treated poorly, right, can have effects on how you know, shape your metabolic profiles in utero, right? I mean, this is huge. And so I think that one of the things that is really important is people talk about, oh, it's just, you know, that happened a long time ago, just get over it. When we see historically and currently how structural inequality as well as these interpersonal interactions are still impacting our children, our families, and our communities. And so it's a public health issue. This is a public health issue that we're dealing with.
Thank you. One last question, one last comment?
We've talked a little bit about people having problems with both schools and health and so on and so forth, and reference has been made to training healthcare workers to be more culturally, racially sensitive and so forth. I'm wondering to what extent do institutions like the Malone Center have training programs for the consumers? That is to say, teaching the people who go to the health care workers how to be assertive, teaching parents a little bit of how to be appropriately assertive in the school system as well.
I think that's for me. Presently, we don't have anything that deals with that. We work with kids and we teach what I would say basic leadership skills and et cetera, but when it comes to parents or with consumers or with clients, we have 2 workers on staff that work with our clients, both Reverend Banks and Reverend Goodman Banks and also Regina Sullivan, and they help clients, what do I say, navigate the healthcare system. But when it comes to our parents, no, we don't have anything in place, and that's something to think about, which I hadn't thought about before. And that's one of the reasons we kind of have these type of discussions. It widens our horizons, and this would be the kind of thing from the research that Dr. Goosby and others are doing. This is the type of thing that we could probably look for funding to see a need to help our community become more assertive with achieving their rights in the healthcare setting. Never thought about it? Thank you. But again, it's based upon the research and something I didn't even think about, but yes, that's a possibility. We could look at the foundation, go to the CDC or somewhere and see if this is something they would buy into, that type of training, that type of help and assistance. Or it could be that we would help our workers become more versed in that area too, and seeking that type of training. So thank you. But no, presently not. We don't. Anything else? Let's give a big round of applause to Dr. Goosby.
Thank you.
Hopefully this is the first in the series of these type of talks that we'll have over the lunch hour. For more information, you can go to our website or also go to mhdi.unl.edu for more information about the Minority Health Disparity Initiative, or again, go to maloncenter.org for information about the programs that we have here. Again, thank you so much for coming. Greatly appreciate your attendance, greatly appreciate your comments and your questions. And if there's anything that any of you would like to do when it comes to Dr. Goosby's research, She'll be afterwards. You can give her a call and you can talk to her further about it. I'm sure she's looking for more people to actively participate in the research that she's doing. So again, thank you so much. And also, we'll see you next time. All righty? Thank you.